Myiasis, also known as fly strike or fly strike, is the parasitic infestation of the body of a live animal by fly larvae, maggots, that grow inside the host while feeding on its tissue. Although flies are most commonly attracted to open wounds and urine or feces-soaked fur, some species, including the most common myiatic flies, the buttfly, blowfly, and screwfly, can create an infestation even on unbroken skin. Non-myiatic flies, such as the common house ephly, can be responsible for accidental myiasis. Because some animals, particularly non-native domestic animals, cannot react as effectively as humans to the causes and effects of myiasis, such infestations present a severe and continuing problem for livestock industries worldwide, causing severe economic losses where they are not mitigated by human action. Although typically a far greater issue for animals, myiasis is also a relatively frequent disease for humans in rural tropical regions where myiatic flies thrive, and often may require medical attention to surgically remove the parasites. Myiasis varies widely in the forms it takes and its effects on those affected. Such variations depend largely on the fly species and where the larvae are located. Some flies lay eggs in open wounds, other larvae may invade unbroken skin or enter the body through the nose or ears, and still others may be swallowed if the eggs are deposited on the lips or food. There can also be accidental myiasis that Aristales tenax can cause in humans via water containing the larvae or in contaminated uncooked food. The name of the condition derives from ancient Greek mu upsilon alpha, mya, meaning fly. Signs and symptoms. How myiasis affects the human body depends on where the larvae are located. Larvae may infect dead, necrotic, prematurely dying, or living tissue in various sites, the skin, eyes, ears, stomach, and intestinal tract, or in genitourinary sites. They may invade open wounds and lesions or unbroken skin. Some enter the body through the nose or ears. Larvae or eggs can reach the stomach or intestines if they are swallowed with food and cause gastric or intestinal myiasis. In extremely rare cases, maggots may occasionally infest the vulvar area. Several different presentations of myiasis and their symptoms. Syndrome symptoms. Cutaneous myiasis: painful, slow-developing ulcers or furuncle, boil-like sores that can last for a prolonged period. Nasal myiasis: obstruction of nasal passages and severe irritation. In some cases, facial edema and fever can develop. Death is not uncommon. Oral myiasis: crawling sensations and buzzing noises. Smelly discharge is sometimes present. If located in the middle ear, larvae may get to the brain. Ophthalmomyiasis: severe irritation, edema, and pain. Fairly common. Wound myiasis in the scalp. Wound myiasis occurs when fly larvae infest open wounds. It has been a serious complication of war wounds in tropical areas and is sometimes seen in neglected wounds in most parts of the world. Predisposing factors include poor socioeconomic conditions, extremes of age, neglect, mental disability, psychiatric illness, alcoholism, diabetes, and vascular occlusive disease. Myiasis of the human eye or ophthalmomyiasis can be caused by Hypoderma tarandi, a parasitic buttfly of caribou. It is known to lead to uveitis, glaucoma, and retinal detachment. Cause. Life cycle. The life cycle in sheep is typical of the disease. The female flies lay their eggs on the sheep in damp, protected areas of the body that are soaked with urine and feces, mainly the sheep's breech, buttocks. It takes approximately 8 hours to a day for the eggs to hatch, depending on the conditions. Once hatched, the larvae then lacerate the skin with their mouth parts, causing open sores. Once the skin has been breached, the larvae then tunnel through the sores into the host's subcutaneous tissue, causing deep and irritating lesions highly subject to infection. After about the second day, bacterial infection is likely and, if left untreated, causes bacterial bloodstream infections or sepsis. This leads to anorexia and weakness and is generally fatal if untreated. Species affecting humans. There are 3 main fly families causing economically important myiasis in livestock and also, occasionally, in humans. Calliphoridae, blowflies. Some examples include Calliphora vomitoria, Calliphora vicina, and Cortylobia. Astridae, botflies. Sarcophagidae, flesh flies. Sarcophaga barbata are usually found in dead and rotting meat and animal excrement, which are prime environments for them. This is because their larvae are facultative parasites, as they feed on organic tissue and use the host's oxygen reserve. Other families occasionally involved are Anisopodidae, Pyophilidae, Stratiomyidae, Syrphidae. Specific myiasis, caused by flies that need a host for larval development. Dermatobia hominis, human buttfly. Cortylobia anthropophaga, tumbu fly. Cortylobia rodhani, Lund's fly. Estrus ovis, sheep buttfly. Hypodermis species, cattle buttflies or ox warbles. Gasterophilus species, horse buttfly. Cochleomya hominivirax, New World screwworm fly. Chrysomyobotziana, Old World screwworm fly. Ochmeromya senegalensis, Congo floor maggot. Cuterebrus species, rodent and rabbit buttfly. Semi-specific myiasis, caused by flies that usually lay their eggs in decaying animal or vegetable matter, but that can develop in a host if open wounds or sores are present. Lucilia species, green bottle fly. Cochleomya species, screwworm fly. Phormia species, black bottle fly. Calliphora species, blue bottle fly. Sarcophagus species, flesh fly or sarcophagids. Flesh flies, or sarcophagids, members of the family Sarcophagidae, can cause intestinal myiasis in humans if the females deposit larvae on meat or fruit. Accidental myiasis. Accidental myiasis is also called pseudomyiasis. It is caused by flies that have no preference or need to develop in a host but may do so on rare occasions. Transmission occurs through accidental deposit of eggs on oral or genitourinary openings, or by swallowing eggs or larvae that are on food. The cheese fly, Pyophila casei, sometimes causes myiasis through intentional consumption of its maggots, which are contained in the traditional Sardinian delicacy casu marzu. Other flies that can accidentally cause myiasis are Muscodomes tica, Haucephali. Phania species, latrine flies. Aristales tenax, rat-tailed maggots. Mucina spp. The adult flies are not parasitic, but when they lay their eggs in open wounds and these hatch into their larval stage, also known as maggots or grubs, the larvae feed on live or necrotic tissue, causing myiasis to develop. They may also be ingested or enter through other body apertures. Diagnosis. Myiasis is often misdiagnosed in the United States because it is rare and its symptoms are not specific. Intestinal myiasis and urinary myiasis are especially difficult to diagnose. Clues that myiasis may be present include recent travel to an endemic area, one or more non-healing lesions on the skin, itchiness, movement under the skin or pain, discharge from a central punctum, tiny hole, or a small, white structure protruding from the lesion. Serologic testing has also been used to diagnose the presence of botfly larvae in human ophthalmomyiasis. Duration, 10 seconds. 0:10. Ultrasound showing maggot infestation. Duration, 14 seconds. 0:14. Ultrasound showing maggot infestation. Ultrasound showing maggot infestation. Ultrasound showing maggot infestation. Classifications. German entomologist Fritz Zumpt describes myiasis as the infestation of live human and vertebrate animals with dipterous larvae, which at least for a period, feed on the host's dead or living tissue, liquid body substances, or ingested food. For modern purposes, however, this is too vague. For example, feeding on dead or necrotic tissue is not generally a problem except when larvae such as those of flies in the family Pyophilidae attack stored foods such as cheese or preserved meats. Such activity suggests saprophagy rather than parasitism. It even may be medically beneficial in maggot debridement therapy, MDT. Currently, Myiasis commonly is classified according to aspects relevant to the case in question. The classical description of myiasis is according to the part of the host that is infected. This is the classification used by ICD-10. For example, dermal, subdermal, cutaneous, B87.0, creeping, where larvae burrow through or under the skin, furuncular, where a larva remains in one spot, causing a boil-like lesion, nasopharyngeal, in the nose, sinuses, or pharynx, B87.3, ophthalmic or ocular, in or about the eye, B87.2, auricular, in or about the ear, gastric, rectal, or intestinal/enteric for the appropriate part of the digestive system, B87.8, urogenital, B87.8. Another aspect is the relationship between the host and the parasite, which provides insight into the biology of the fly species causing the myiasis and its likely effect. Thus the myiasis is described as either obligatory, where the parasite cannot complete its life cycle without its parasitic phase, which may be specific, semi-specific, or opportunistic; facultative, incidental, or accidental, where it is not essential to the life cycle of the parasite, perhaps a normally free-living larva accidentally gained entrance to the host. Accidental myiasis commonly is enteric, resulting from swallowing eggs or larvae with one's food. The effect is called pseudomyiasis. One traditional cause of pseudomyiasis was the eating of maggots of cheese flies in cheeses such as Stilton. Depending on the species present in the gut, pseudomyiasis may cause significant medical symptoms, but it is likely that most cases pass unnoticed. Prevention. The first control method is preventive and aims to eradicate the adult flies before they can cause any damage and is called. The second control method is treatment once the infestation is present, and concerns the infected animals, including humans. The principal control method of adult populations of myiasis-inducing flies involves insecticide applications in the environment where the target livestock is kept. Organophosphorus or organochlorine compounds may be used, usually in a spraying formulation. One alternative prevention method is the sterile insect technique, SIT, where a significant number of artificially reared sterilized, usually through irradiation, male flies are introduced. The male flies compete with wild breed males for females to copulate and thus cause females to lay batches of unfertilized eggs that cannot develop into the larval stage. One prevention method involves removing the environment most favorable to the flies, such as by removal of the tail. Another example is the crutching of sheep, which involves the removal of wool from around the tail and between the rear legs, which is a favorable environment for the larvae. Another, more permanent, practice that is used in some countries is mulesing, where the skin is removed from young animals to tighten remaining skin, leaving it less prone to fly attack. To prevent myiasis in humans, there is a need for general improvement of sanitation, personal hygiene, and extermination of the flies by insecticides. Clothes should be washed thoroughly, preferably in hot water, dried away from flies, and ironed thoroughly. The heat of the iron kills the eggs of myiasis-causing flies. Treatment. This applies once an infestation is established. In many circles, the first response to cutaneous myiasis once the breathing hole has formed, is to cover the air hole thickly with petroleum jelly. Lack of oxygen then forces the larva to the surface, where it can more easily be dealt with. In a clinical or veterinary setting, there may not be time for such tentative approaches, and the treatment of choice might be more direct, with or without an incision. First, the larva must be eliminated through pressure around the lesion and the use of forceps. Secondly, the wound must be cleaned and disinfected. Further control is necessary to avoid further reinfestation. Livestock may be treated prophylactically with slow-release boluses containing ivermectin, which can provide long-term protection against the development of the larvae. Sheep also may be dipped, a process that involves drenching the animals in persistent insecticide to poison the larvae before they develop into a problem. Epidemiology. Main article, Fly strike in sheep. Myiasis is prevalent in livestock, and especially in domestic sheep. Myiasis in sheep is often caused by blowflies, Lucilia sericata and L. cuprina in particular, and is commonly referred to as blowfly strike. Blowfly strike, and other fly strike, occurs worldwide but is most common in regions where hot and wet conditions are sustained, such as sub-Saharan Africa, Southeast Asia, Latin America, Australia, and New Zealand. As of 2021, blowfly strike accounts for over $280 million a year in losses for the Australian sheep industry. As mitigation, Australian sheep farmers may engage in mulesing, a procedure designed to remove strips of wool-producing skin that are the most common targets for flies. Farmers may also dock lambs' tails to reduce the likelihood of infestation. However, both mulesing and tail docking have received criticism from animal welfare groups, who say the mitigative procedures are excessive and can have other negative effects. In addition to blowfly strike in sheep, myiasis from screwworm flies, Cochleomyia hominivirax in particular, regularly cause upwards of $100 million in annual damages to domestic cows and goats. Screwworm-related myiasis is primarily mitigated through the sterile insect technique. History: myiasis in a cat's flesh. Myiasis in a dog's flesh. Frederick William Hope coined the term myiasis in 1840 to refer to diseases resulting from dipterous larvae as opposed to those caused by other insect larvae. The term for this was scolechiasis. Hope described several cases of myiasis from Jamaica caused by unknown larvae, one of which resulted in death. Even though the term myiasis was first used in 1840, such conditions have been known since ancient times. Ambroise Paré, the chief surgeon to King Charles IX and King Henry III, observed that maggots often infested open wounds. Maggot therapy. Main article: Maggot therapy. Throughout recorded history, maggots have been used therapeutically to clean out necrotic wounds, an application known as maggot therapy. Fly larvae that feed on dead tissue can clean wounds and may reduce bacterial activity and the chance of a secondary infection. They dissolve dead tissue by secreting digestive enzymes onto the wound as well as actively eating the dead tissue with mouth hooks, two hard, probing appendages protruding on either side of the mouth. Maggot therapy, also known as maggot debridement therapy, MDT, larval therapy, larva therapy, or larvae therapy, is the intentional introduction by a healthcare practitioner of live, disinfected green bottle fly maggots into the non-healing skin and soft tissue wounds of a human or other animal for the purpose of selectively cleaning out only the necrotic tissue within a wound to promote healing. Although maggot therapy has been used in the US for the past 80 years, it was approved by the FDA as a medical device only in 2004, along with leeches. Maggots were the first live organism to be marketed in the US according to FDA regulations, and are approved for treating neuropathic, diabetic, foot ulcers, pressure ulcers, venous stasis ulcers, and traumatic and post-surgical wounds that are unresponsive to conventional therapies. Maggots were used in medicine before this time, but were not federally regulated. In 1990, California internist Ronald Sherman began treating patients with maggots produced at his lab at the UC Irvine School of Medicine. Sherman went on to co-found Monarch Labs in 2005, which UC Irvine contracted to produce maggots for Sherman's own continuing clinical research on myiasis at the university. Monarch Labs also sells maggots to hospitals and other medical practices, the first U.S. commercial supplier to do so since the last one closed in 1935. In the U.S., demand for these fly larvae doubled after the FDA ruling. Maggot therapy is now used in more than 300 sites across the country. The American Medical Association and Centers for Medicare and Medicaid Services recently clarified the reimbursement guidelines to the wound care community for medicinal maggots, and this therapy may soon be covered by insurance. The larvae of the green bottle fly, Lucilia fly, are now used exclusively for this purpose, since they preferentially devour only necrotic tissue, leaving healthy tissue intact. This is an important distinction, as most other major varieties of myiacitic fly larvae attack both live and dead wound tissue indiscriminately, effectively negating their benefit in non-harmful wound debridement. Medicinal maggots are placed on the wound and covered with a sterile dressing of gauze and nylon mesh. However, too many larvae placed on the wound could result in healthy tissue being eaten, efficiently creating a new wound, and rendering it a type of myiasis. History. Maggot therapy has a long history and prehistory. The indigenous people of Australia used maggot therapy, and so do the hill peoples of northern Burma, and possibly the Mayans of Central America. Surgeons in Napoleon's armies recognized that wounded soldiers with myiasis were more likely to survive than those without the infestation. In the American Civil War, army surgeons treated wounds by allowing blowfly maggots to clean away the decayed tissue. William Baer, an orthopedic surgeon at Johns Hopkins during the late 1920s, used maggot therapy to treat a series of patients with osteomyelitis, an infection of bone or bone marrow. The idea was based on an experience in World War I in which two soldiers presented to him with broken femurs after having lain on the ground for 7 days without food. Baer could not figure out why neither man had a fever or signs of sepsis. He observed, on removing the clothing from the wounded part, much was my surprise to see the wound filled with thousands and thousands of maggots, apparently those of the blowfly. The sight was very disgusting and measures were taken hurriedly to wash out these abominable-looking creatures. However, he then saw that the wounds were filled with beautiful pink granulation tissue and were healing well. Maggot therapy was common in the United States during the 1930s. However, during the second half of the 20th century, after the introduction of antibiotics, maggot therapy was used only as a last resort for very serious wounds. Lately maggots have been making a comeback due to the increased resistance of bacteria to antibiotics. Title: Myiasis, The Nightmare Within. Intro: A Nightmare in Flesh. They say horror lives in the dark corners of the unknown, but sometimes, it lives inside you. Myiasis is not just a disease. It is a waking nightmare. A condition so viscerally disturbing, so grotesquely invasive, that even seasoned doctors often flinch. Imagine this: you wake up one morning with a small bump on your skin. It itches, maybe stings a little. A mosquito bite, you think. But days pass, and the bump grows. It pulses. It oozes. You feel something squirm. Then you see it tiny, white, wriggling. Living inside you. This is not fiction. This is not the product of imagination. This is a parasitic reality, a fly's maggot chewing through your flesh while you're still alive. Welcome to the world of myiasis. Chapter 1, What is myiasis? Myiasis is the infestation of live human or animal tissue by fly larvae. These larvae, commonly referred to as maggots, feed on the living or necrotic tissue of their hosts. The term is derived from the Greek word mya, meaning fly. The primary culprits are flies of the order Diptera, especially species like Cochleomya hominivirax, New World screwworm, Dermatobia hominis, human buttfly, and Lucilia sericata, green bottlefly. Types of myiasis include 1. Cutaneous myiasis, the most common form, where larvae invade the skin. 2. Wound myiasis, infestation of pre-existing wounds. 3. Nasopharyngeal myiasis, invasion of nasal passages and sinuses. 4. Ophthalmomyiasis, infestation in the eye. 5. Enteric myiasis, occurs when larvae are ingested and survive in the GI tract. These invasions are categorized as obligatory myiasis, where the larvae must live in a host to complete their life cycle. Facultative myiasis, opportunistic infestation of necrotic tissue. Accidental myiasis, ingestion or contact with larvae accidentally, not by intent of the fly. Chapter 2, The Life Cycle of the Enemy. Understanding myiasis requires understanding the life cycle of the parasitic flies. 1. Egg stage, female flies lay hundreds of eggs, often on open wounds, damp clothing, or directly on the skin. 2. Larval stage, within hours, eggs hatch. Larvae burrow into flesh, releasing enzymes to liquefy tissue. 3. Feeding, they feed on healthy or necrotic tissue for several days to weeks. 4. Pupation, after feeding, they drop off and pupate in the soil. 5. Adulthood, emerging as adult flies, the cycle continues. In the case of the human butterfly, for instance, a mosquito is hijacked to deliver eggs onto human skin. When the mosquito bites, body heat triggers the hatching of larvae, which then burrow into the skin. Chapter 3, Infestation, the biological horror. Once inside the host, the larvae anchor themselves using hook-like mouthparts. They begin releasing proteolytic enzymes, breaking down tissue and feeding on the resultant slush. The symptoms vary depending on the site of infestation. Localized pain. Intense itching. A sensation of movement under the skin. Discharge of pus or serous fluid. Visible maggots protruding from lesions. In ocular or nasal infestations, patients may experience severe pain, vision disturbances, nasal congestion or bleeding, psychological distress and panic. These maggots are not passive residents. They are destructive invaders. Their mere presence triggers inflammation, immune responses, and sometimes systemic infections. Chapter 4, True Cases of Myiasis. 1. The soldier in Colombia. A young soldier stationed in the Colombian rainforest develops a boil on his arm. It worsens, and he complains of something moving. When medics investigate, they find 3 Dermatobia hominis larvae inside. 2. The eye of horror. In Ethiopia, a young boy complains of severe eye pain and swelling. Doctors discover ophthalmomyiasis, a larva wriggling inside his eye socket. Immediate surgery is required to save his vision. 3. Nasal nightmare. An elderly homeless man in Mumbai with poor hygiene presents with foul-smelling nasal discharge. Inside his nose. Over 50 maggots. 4. The Amazonian traveler. A tourist returns from Peru with a persistent lesion on her scalp. Doctors extract a live butterfly larva after weeks of growth. 5. The diabetic foot. A diabetic patient with an untreated foot ulcer develops maggot infestation. The wound becomes necrotic, leading to amputation. Chapter 5, The Flies of Death. Each species of fly involved in myiasis has evolved specific strategies. Screwworm fly, Cochleomya hominivirax, lays eggs in open wounds. Larvae feed on healthy tissue in a screw-like motion. Buttfly, Dermatobia hominis, uses mosquitoes to deposit eggs on the skin. Blowflies, Lucilia sericata, prefer necrotic tissue, often used medically in maggot therapy. Their adaptations include heat detection, tissue-specific enzymes, anti-predator burrowing. Some are drawn to the scent of decay, while others are attracted to blood or carbon dioxide. Chapter 6, Geography of Myiasis. Myiasis is more prevalent in tropical and subtropical regions, rural areas with poor hygiene and limited medical access, places with livestock and abundant flies. Countries like Brazil, India, Nigeria, and parts of Southeast Asia report high incidences. However, globalization and climate change have allowed these flies to expand their reach. Urban cases are rising. Travelers and migrants bring infections across borders. And with warming temperatures, fly ranges are extending into temperate zones. Chapter 7, Treatment and Removal. Removal is urgent. Methods include 1. Manual extraction, using tweezers to pull out larvae. Difficult if larvae anchor deeply. 2. Occlusion therapy, applying petroleum jelly or bacon strips to block the larva's breathing hole, forcing it to surface. 3. Surgical debridement, for large or internal infestations. 4. Larvicidal agents, topical or systemic medications. 5. Antibiotics, to prevent secondary bacterial infection. In some cases, improper removal leads to partial larval death inside the body, causing abscesses, sepsis, or chronic inflammation. Chapter 8, Prevention. Preventive measures include wearing insect repellent in endemic regions, avoiding sleeping outdoors without nets, boiling or ironing clothes. Flies lay eggs on damp fabric. Promptly treating wounds. Maintaining good hygiene. Travelers to rainforest regions should be especially cautious. Many infections occur due to ignorance or neglect. Chapter 9, Psychological Trauma. Beyond the physical, myiasis scars the mind. Victims report PTSD-like symptoms. Anxiety, nightmares, paranoia. Social stigma from visible scars. Fear of reinfestation. Children, elderly patients, and those with psychiatric illness are especially vulnerable. In some cases, psychological distress persists long after the larvae are removed. Chapter 10, When it kills. While rarely fatal, myiasis can be deadly when infestation is untreated and spreads. Secondary infections enter the bloodstream. Occurs in immunocompromised patients. Larvae penetrate vital areas like the brain or eye. Several deaths are reported annually in developing nations due to neglected cases. In others, myiasis complicates existing conditions, accelerating decline. Conclusion, a crawling reminder. Myiasis is a reminder that nature is not always benign. It is a crawling, wriggling testament to evolution's creativity and cruelty. It violates the boundary between self and other. Between human and parasite. Between life and decay. But it also speaks of resilience. Of medicine's power to fight back. Of awareness, hygiene, and vigilance. The more we understand these creatures, the more we can protect ourselves. Until then, keep your wounds clean. Keep your skin covered. And remember, somewhere, a fly waits. Not for death, but for life. Inside you.